نعم دكتور تفضل.
اوكي. السلام عليكم اخوان، زميلاتي زملائي المحترمين، اهلا وسهلا بكم لهذا النشاط العلمي الجديد اللي نبدي بالتعاون ويا شركة ميرك. الحقيقة احنا في هذا الاكتيفيتي حاولنا we address certain needs of the practicing doctors about beta blocker. As you know, the title of our session is the role of beta blocker in the management of cardiovascular disease. And therefore, for this reason, we select a distinguished speakers for you this time or this night. And I hope الآن السلايد تشوفوه شباب.
Yes.
Okay. مثل بالبداية حاب أعرفكم نفسي. أنا دكتور هلال الصفار, consultant cardiologist, College of Medicine, University of Baghdad. I am currently the international advisor for the Royal College of Physicians in London. One of our distinguished speaker will be Dr. Aram Jamal. Dr. Aram is a consultant interventional cardiologist. He is the ex-manager of Suleimaniya Cardiac Center. He is an eminent Iraqi and Middle East interventional cardiologist, and he did a lot of work in interventional cardiology, and he have a very great respect from his colleagues inside and outside Iraq. Dr. Aram will address the issue of beta blocker in patients with coronary artery disease as well as in patients with heart failure. Our second distinguished speaker will be Dr. Ala Sheikh. Dr. Ala is a consultant nephrologist. He is working in the renal transplant center in the medical city. Dr. Ala is one of the prominent nephrologists in the country, and he's a very good lecturer, and educational activities were highly respected in the past time. Dr. Ala will talk about the use of beta blocker in patients with hypertension as well as in those patients with a chronic kidney disease. But before opening the floor for our respectable speakers, we want to know what is the aim of these educational objectives. As you all know, now there is what is called webinaritis. There is webinar fatigue, as they call it. So many activities here and there, but what distinguishes this activity is that has a specified tasks, and we want to answer certain questions. What are these questions? The first one is that what is the role of beta blocker in patients with hypertension? If we have pure hypertension or we have hypertension with comorbidities, mainly ischemic heart disease and heart failure. So what is our choice? The second question is that are all beta blockers are equal in the management of heart failure, or there is a difference between beta blockers? And this brings us to the terminology of guideline-directed management and therapy. We want to shed light on this point. The third question is that how can we be sure that our patients are adequately beta blocked? وبصراحة بدي أتكلم بالعربي، هواية مرضى نعطيهم بيتا بلوكر لكن إحنا ما محققين الغاية من البيتا بلوكر in those patients. So what will be our targets in the use of beta blocker? The fourth is that what shall we do if we have a patient who have ischemic heart disease or heart failure and we need beta blocker, but the patient has chronic obstructive airway disease? What to do in this condition? And then the other question is that what about the fear from complications or side effects, especially male impotence? And a lot of patients is talking about what if I have impotence after beta blocker? What shall we do? And then how to titrate up or up titration of the dose of the beta blocker to reach to the required outcome. And the other question is that which beta blocker to be chosen for which patient? Is there a difference or they are alike? That means is that a specific effect of a drug or it is a class effect as a beta blocker? The eighth question is that what about beta blocker and chronic kidney disease? Dr. Ala would address this issue in details. And then what about if we want to do a surgery for a patient with beta blocker, what to do? And lastly, what we have to do if we want to withdraw beta blocker from the patients. These questions are frequently we came across during our clinical life. We will try to, in a summarized way, focused way, to deliver messages to the audience regarding these questions. Now, I shall stop sharing my screen. And may I ask our first speaker, Dr. Aram Jamal, to talk about beta blocker in the management of patients with ischemic heart disease and heart failure. Dr. Aram, the floor is yours.
Thank you very much, sir. Let me.
Okay, it's now obvious, Aram.
Can you hear me, sir?
Yes, clearly we
Yeah.
can hear you.
Ladies and gentlemen, and the video is open. Sorry.
Yes.
Okay. Okay. Thank you very much, ladies and gentlemen, dear all my colleagues and friends. Good evening. Before I'm going to deliver my speech, I would like to thank you, my mentor and my idol, Dr. Al-Saffar, who invited me to be part in this scientific activity. Also, I'd like to thank Merck Manufacturing Company for making this event to happen. Today, in the next 20 minutes, I'm going to talk about the role of the beta blockers in the management of the heart failure and in the management of coronary artery disease. And
عفوا آرام بس الفيديو مالتك افتحها آرام. Open your video بس الفيديو مالتك.
اوكي عمي
بس على اسمك والاسمك اوكي لا الفيديو فوق بس open it.
اوكي
لا
عمي. Okay, so is now okay, Absia?
Yes, now it's okay. Very okay now.
So as obeying to the instruction by my idol, Dr. Hilal, I am going to touch the key points in a very simplified way. So I'm going to talk about the role of the beta blockers in the coronary artery disease and heart failure in a very simplified way. Just historically speaking, beta blocker was first invented by Mr. James Black in Imperial Chemical Industries in United Kingdom just in 1962. 26 years later, after that his invention, he awarded a Nobel Prize in the medicine. Another gentleman was David Lewis Agnero. Also, he was awarded a Nobel Prize in medicine. He's saying that the famous word that we can reverse cardiovascular damage with nitric oxide. And he said that nebivolol promises to be a unique drug for the treatment of multiple cardiovascular disorders. So we have got two guys, both of them, they won a Nobel Prize for their participation in the innovation and developing some type of beta blockers. So the skeleton of my presentation today will be 4 questions and addressed by Dr. Saffar. The first question will be, should beta blocker be considered in all patients with heart failure with reduced ejection fraction? The second question will be, do beta blockers have a role in the management of heart failure with mid-range ejection fraction and with those patients with heart failure with preserved ejection fraction? The third one will address how should beta blockers should be used in patients with acute coronary syndrome. And the last question, we are going to talk about the indication whether beta blockers are indicated in those patients with chronic coronary syndrome without acute coronary syndrome. So the skeleton of the presentation will address these 4 questions. Just to know the terminology of the heart failure, previously we were having 3 types of heart failure. Just when we say heart failure with a reduced ejection fraction, it means that the ejection fraction is below 40. When we say previously, we have one term, heart failure with preserved ejection fraction having A and B. In A, we have got borderline preserved ejection fraction and improved preserved ejection fraction. When we say improve, it was the ejection fraction should bet to be more than 40%, while to say borderline, it was between 49 and 41 to 49%. But recently, in the last year, this have been changed with another terminology, which is heart failure with mid-range ejection fraction. So nowadays, we have got three types of heart failure. The first one is heart failure with reduced ejection fraction, in which the patient have got symptom of heart failure and the ejection fraction should be below 40%. The second one is heart failure with mid-range ejection fraction, in which this symptomatic patient have an ejection fraction of between 40 to 49% and plus elevation of the natriuretic peptide plus at least one of the additional criteria like left ventricular hypertrophy, left atrial dilatation, or diastolic function. And the last type, or the third one, of ejection of heart failure is heart failure with preserved ejection fraction, in which these patients, symptomatic patients, they have got symptom of heart failure, but by echocardiography, the ejection fraction is equal or more than 50%. However, they have got elevated natriuretic peptide level or other structural disease like LVH, left atrial dilatation, or diastolic function. So when we are going to talk about the heart failure, we should keep in mind we are going to talk about three main types of heart failure, which are heart failure with a reduced ejection fraction, mid-range, and preserved ejection fraction. So going back to the skeleton of the presentation, the first question was the address: should beta blocker consider in all patients with a reduced ejection fraction? To answer this question, we should know the pathophysiology of heart failure. I'm going to talk about the pathophysiology within about 30 seconds, because you know that the pathophysiology of heart failure is too long. But just to simplify that, we know that the etiology of heart failure with a reduced ejection fraction is varied. It by characterized by reduced ejection fraction. One of the important things, or the cornerstone for the pathophysiology of heart failure with reduced ejection fraction, is adrenergic activation, which is initially the adaptive response to the reduction in the cardiac function. So when you have got reduction in the cardiac function, this in turn leads to the stimulation of the cardiac and central neuron system and renin, angiotensin, aldosterone system. And this in turn leads to the increased release of epinephrine and norepinephrine by the cardiac sympathetic nerve terminals, and this in turn leads to the augmentation of the heart rate, contractility, and the blood pressure. So excess and chronic catecholamine stimulation eventually lead to the desensitization and downregulation and subsequent decline in the inotropic reserve of the heart. And this in turn lead to the myocardial apoptosis and fibrosis, and then lead to the arrhythmia. So the main factor which lead to the progression of the heart failure is adrenergic activation and increased release of the catecholamine. What is the beta blocker is doing? Beta blocker have proven to be effective in the reducing the deleterious effect of the adrenergic activation. So it should be used in all patients with heart failure with reduced ejection fraction, because all the trials have found that this will decrease the cardiac death. So the main action of the beta blocker will interrupt this cycle of activation of catecholamine release. Just is going back 5 decades or 4 decades ago, in 16 or 70s, beta blocker were contraindicated in any patient with heart failure. So nobody were prescribing any kind of beta blocker for patients with heart failure. But big change have been done in the 2 or 3 decades, because a lot of trials done on some beta blockers like bisoprolol, metoprolol, and carvedilol. All these trials, like CIBS2 for the bisoprolol, for the metoprolol we have got MERIT heart failure, and for the carvedilol there is a big trial, was Copernicus trial. All these trials found that giving beta blocker in those patients with heart failure with reduced ejection fraction, they will significantly decrease the mortality and mortality. And it will lead to the improvement in the quality of life. So they are not only affecting the mortality, but they will also improve the functional capacity, and they will improve the quality of life. This is the result of a lot of randomized controlled trial. All the trial have found only these beta blockers, bisoprolol, metoprolol, and carvedilol, are effective in the treatment of heart failure with reduced ejection fraction. And this is the characteristic of different kind of beta blockers using in the management of the heart failure. If you look to all of them have been proved, but unfortunately, bisindolol, there are no any trial. There are some trial on that bisindolol, but all of them fail to show that there is any mortality benefit of giving bisindolol in patients with heart failure with reduced ejection fraction. So the only medication, beta blockers, have been proved to be effective in decreasing mortality and morbidity in patients with heart failure with reduced ejection fraction are bisoprolol, metoprolol, and carvedilol. And one of the important points that have been addressed by Dr. Saffar is the dosing of the beta blocker is very important. Daily, I have seen patients coming to our clinic, they are on bisoprolol 2.5 milligram for the last 10 years. We have seen a lot of patients on carvedilol on 2.5 milligram twice a day for about 15 years. But this is the wrong tradition. So we should up-titrate the dose of the beta blocker till we reach the target dose. So the target dose for the bisoprolol is 10 milligram per day. For the metoprolol tartrate, we should start with 12.5 per day to increase the maximum dose of 50 to 75 milligram twice a daily. Metoprolol succinate is the same. We will start with 12.5 milligram daily. The maximum dose of metoprolol succinate, which is the long-acting one, is 200 milligram per day. And that one for the carvedilol, the starting dose should be 3125 twice per day, up to 25 to 50 milligram twice per day. So please keep this in mind. When we are starting giving beta blocker, do not stick to the fixed dose unless there are contraindication for that. Whenever we have got no contraindication, we should gradually increase the dose, and we should reach the target dose as mentioned in here. Bisoprolol should be 10 milligram, metoprolol succinate up to 200 milligram, metoprolol tartrate up to 75 milligram twice a day, and carvedilol up to 25 to 50 milligram twice per day. So these are very, very important. So from this available data that we have presented now simply, if we go to answer the question, should beta blockers to be considered in all patients with heart failure with reduced ejection fraction, actually the answer for that will be yes, because beta blockers have been proven to be highly effective in improving survival. So do not forget these three types of beta blocker. They will decrease mortality and they will improve the functional capacity in those patients with heart failure with reduced ejection fraction. As you mentioned, the most studied beta blockers are carvedilol, metoprolol, and bisoprolol. One of the important points, as we said, start low dose and up titrate to the target dose. Please do not fix to the one dose for a long period of time. We should up titrate. If we go to the second part of second question in the skeleton of the presentation, do beta blockers have a role in the management of heart failure with mid-range ejection fraction or preserved ejection fraction? So we say that the first part was about reduced ejection fraction. So this part we are going to talk about the role of the beta blockers in patients with heart failure with mid-range and preserved ejection fraction. If we want to answer this question, it is very easy. We should go back 4 slides back. We say that the backbone or the pathophysiology of the heart failure with reduced ejection fraction is adrenergic activation. That's why beta blocker are effective. So we should ask some question here. Does adrenergic activation play similar role in patients with heart failure with mid-range and preserved ejection fraction or not? Actually, till now, there are no clear data proving that in this population, in those people with heart failure with mid-range and preserved ejection fraction, there is no any chronic adrenergic activation. So theoretically speaking, there is no role of beta blocker in these people, unless there are other indication. For example, if you have a patient with hypertension, we knew that hypertension might cause some sort of heart failure, preserve ejection fraction. At that time, beta blocker will be the first line or second line of treatment. But if you have got heart failure with mid-range or preserve ejection fraction, there are no any clear data. This is a data from several randomized trials. All of them have studied the role of these. This is the meta-analysis of 11 randomized controlled trials. They have studied the effect of beta blocker on those patients with heart failure with preserved and mid-range ejection fraction. They study the all-cause mortality and cardiovascular mortality. If we look to this figure, there is some statistical, some in group with mid-range ejection fraction, there is some statistically improvement in the term of mortality. But in those people with preserved ejection fraction, there is no any role even for the mortality in the hospital for those patients. But the problem that the number in these trials are very few. So we need a larger randomized trial to answer this question. But up to time, what is available that there is, if we're going to answer the question whether beta blocker are useful in patients with heart failure with mid-range and preserved ejection fraction, till now we can answer that the evidence is uncertain. It's unlike heart failure with reduced ejection fraction. So there are only suggestive evidence, not solid base evidence, only suggestive evidence that beta blocker might be beneficial in those patients with heart failure with mid-range ejection fraction. But there are little indication for those with preserved ejection fraction. That's why there are a further study with large number of patients needed to answer the question. So that part, these two parts, we talk about the heart failure. So we say that if we go back, beta blocker are highly indicated in those patients with heart failure with reduced ejection fraction, but they are uncertain. They have uncertain role in those patients with mid-range and preserved ejection fraction. Now we are going to move to the second part of the presentation that we are talking about, the beta blocker in acute coronary syndrome. Shall beta blocker should be used in all patients with acute coronary syndrome? To answer the question, we should go back again to the pathophysiology of the heart failure to see whether adrenergic activation is a part of acute coronary syndrome. Definitely yes. Any patient with acute coronary syndrome, they will have got excess release of catecholamine, and that's why it leads to the risk of developing atrial and ventricular arrhythmias and promotion of ventricular remodeling, systolic dysfunction, and heart failure. So the pathophysiology of acute coronary syndrome is definitely the same as heart failure with reduced ejection fraction. And there are a lot of studies and trials. They have tested the effect of beta blocker on patients with acute coronary syndrome. They test the immediate benefit of the beta blockers, and they test the effect on the beta blocker for up to 3 years. One of the very famous trials is Capricorn trial. In this, they brought about 1,850 patients. Those patients with LV dysfunction of the myocardial infarction with ejection fraction below 40. They divide the patient into two groups. One group giving them carvedilol and they up-titrate the dose, and the second group placebo. And they found that there is a very good statistical improvement in the carvedilol arm. And they found that there is those patients who receive carvedilol, there will be a decrease in the mortality up to 33%. So according to that trial and according to the guideline, we can answer this question by yes. Should beta blocker used in patient acute coronary syndrome, the cancer? We can answer this question precisely with yes, because we have a lot of evidence supporting the use of beta blocker in patients with acute coronary syndrome. There is another issue, how we can start this medication, how beta blocker should be started or initiated. We should initiate the treatment at a low dose, and we should up-titrate the dose gradually to prevent the adverse effects. in the absence of contemporary trials. These medication or beta blockers should be used for up to 3 years. But we don't know what will happen in the next few weeks, months, years. There may be some contemporary trial against the use of the beta blocker in those patients with heart failure, with acute coronary syndrome. One of the important issues is that what about patients with ST elevation, myocardial infarction, and normal ejection fraction? Actually, this is still controversy according to the guideline, but there's a big trial whose name is DAM-BLOCK trial. DAM-BLOCK trial is going to test the efficacy of beta blocker in patients with ST elevation MI with normal ejection fraction. As mentioned by Dr. Hilal, the purpose of giving this presentation is to be guideline mediated directed medical therapy. So I brought some guidelines in the new guidelines. This is from European Society of Cardiology this year, is raised just 2 months ago, and mentioned that in those patients with acute coronary syndrome, beta blocker are recommended in patients with ongoing ischemic symptoms and without contraindication. The use of the beta blocker, according to the guideline, is class 1 indication for those patients with acute coronary syndrome. It's recommended to continue beta blocker therapy unless the patient is in over heart failure. So according to the latest guideline, in all patients with acute coronary syndrome, beta blocker should be started unless there are contraindication, and they should be used chronically unless there are contraindication for that. Also, according to the guidelines, beta blocker should be used in all patients with LV systolic dysfunction, with ejection fraction with less than 40%, with heart failure or prior MI, unless contraindicated. So again, it's class 1A indication. So any patient with acute coronary syndrome who have got a reduced ejection fraction, definitely according to the European guideline, using beta blocker is the class 1 indication. Again, beta blocker should be started and continued for 3 years in all patients, even with normal ejection fraction. So the guideline, the last guideline, says that in any patient who have got acute coronary syndrome, when it doesn't have any kind of contraindication, start beta blocker and continue for 3 years, even with the normal ejection fraction. Those was related to the acute coronary syndrome. What about the role of the beta blocker in chronic coronary syndrome in patient stable coronary artery disease? But nowadays the terminology have changed to the chronic coronary syndrome. Actually, by the guidelines, beta blocker may be considered as a chronic therapy for all patients other than who have got normal ejection fraction. So it's class 2 indication. So given beta blocker for those patients with chronic coronary syndrome is class 2B indication. So it's not highly indicated. It's those patients with acute coronary syndrome with a reduced ejection fraction. We have a lot of trials talking about giving medical treatment. I'm going to talk about the few trials that are addressing the medical treatment for patients with chronic coronary syndrome. So it means that patients with ischemic heart disease or coronary heart disease who are stable. We are not talking about the acute coronary syndrome. One of these good examples is Courage trial. In Courage trial, they brought a large number of the patients. They divide the patient, it was about 2,287 patients. They divide the patient whether to the PCI versus medical treatment. And after for 7 years, they found that there is no any mortality benefit of PCI versus medical treatment. They did further follow up for about 50% of the patient up to 15 years. Even after 15 years, they haven't found any benefit of stenting or PCI against medical treatment for those patients with chronic coronary syndrome. So the results were the same. Another trial, which is Orbiter trial, and the Orbiter trial, the main investigator was Dr. Rashad Lamy, who was an Iraqi scientist. Also, the result was, for a period of time, it was controversy because they have found that any patient with chronic stable angina, chronic coronary syndrome with single vessel disease, excluding left main stem, medical treatment is the same to the PCI in the of mortality. The same is true for ischemia trial. In the ischemia trial, they have found for those patients with multivessel disease, three-vessel disease, with normal ejection fraction, excluding left main stem, they found the same result that PCI medical treatment are the same in the term of mortality. So, in those, all the trials have found that in those patients with chronic coronary syndrome, medical treatment is equal to the PCI in the term of the mortality. So the question we address that how beta blocker should be used in patients with chronic coronary syndrome. The answer is yes, we can use it, but for what is not mortality benefit, as is very clear from these respectful trials. It is only for the relief of the angina. It's only for the relief of the angina. So in those patients with chronic coronary syndrome, beta blocker can be given very widely. It's with different story. It's not for the relief of the. It's only for the relief of the angina and not for mortality benefit. And this is the guideline for the treatment, European guideline for the treatment of the angina. It's mentioned that the beta blocker, the first line treatment indicates is beta blocker and or calcium channel blocker. So it's class 1 indication. So according to the guideline, European guideline, in those patients with chronic coronary syndrome, beta blocker should be the first line treatment. And we knew that from these big trials that medical treatment is equal to the PCI in the term of the mortality. So it means that beta blocker have a big role in treating these patients. And then another point is that we can combine beta blocker with dihydropyridine calcium channel blocker, which is class 2 indication. So, according to the guidelines, beta blocker should be prescribed as initial therapy for relief of the symptom for angina pain in patients with chronic coronary syndrome. Just this is the stepwise strategy for the treatment of chronic coronary syndrome. The first step is to start beta blocker or calcium channel blocker. If the patient is still symptomatic, do not forget, please, we are talking about the symptom angina relief. Please combine beta blocker and dihydropyridine calcium channel blocker, unless you can add other third line like ranolazine, trimetazidine, nicorandil can be added in the last step, however, right in the third step. So all the guidelines mention that for the medical treatment of chronic coronary syndrome, beta blocker is the first line of the treatment. I don't know how the time is remaining for me. There are 2 points which are very, very important and addressed by Dr. Hilal, that beta blocker and erectile dysfunction. I'm sure that in our daily practice, daily we are facing patients that come in to our clinic. So can I have two slides, or shall I go to the take-home message? We are keeping these 2 slides for discussion.
Okay, this is an important issue, Aram. Take a couple of minutes just for that.
Yeah. Okay, so I'm sure in our daily practice, we are facing a lot of people coming back. Doctor, please, I've got erectile dysfunction. I've got this impotence. It's your medication. They told me. I read about it in Google. I don't know a lot of things. Actually, this story is true. One of the problem with the side effect of antihypertensive medication like beta blocker, even ARBs and diuretic, all of them, they are causing some sort of erectile dysfunction. The mechanism behind making asexual dysfunction or erectile dysfunction with beta blocker is that the beta blocker, as we said, they will inhibit sympathetic nervous system. And this sympathetic nervous system is involved in the integration of the erection, emission and ejaculation, and regulation of the luteinizing hormone and secretion and stimulation of the testosterone hormone. So imagine that when we are giving beta blocker, we are going to harm all these mechanisms of sexual arousal. So because there are a large number of people are claiming it's not mandatory to be related to the beta blocker, claiming they have got erectile dysfunction secondary to the as a side effect of the beta blocker, this have increased the risk of withdrawal. And one of the guidelines, what was it was amazing to me, the guideline regarding the management of erectile dysfunction published by British Society of Sexual Medicine highly recommend routine assessment of the sexual function prior to the initiation of antihypertensive medication. So according to the British guideline for the sexual medicine, they recommend that to assess the sexual function for any patient before starting antihypertensive, whether it's beta blocker, whether it's IRBs, whether it's IC inhibitors, or even a diuretic. Another important point, how to solve this problem. If a patient comes to me or visits tomorrow and say, doctor, I've got impotence after you gave me medication, what shall we do? Shall we stop the medication or we have a choice? Actually now, nebivolol, which is a novel third generation beta-1 blocker with a greater degree of selectivity, might be a solution. And there are some evidence that nebivolol per se would improve erectile function, not only because it is highly selective, but we know that it's producing nitric oxide, and nitric oxide is one of the vasodilator. It might be effective in improving the erectile function. So the solution for that problem is changing the medication, nebivolol, if there is no contraindication for that. Another important thing that in the beta blocker is beta blocker with chronic obstructive airway disease. Previously, we knew that it was contraindicated. Beta blocker shouldn't be given to any patient with COPD. But nowadays, the selective one, bisoprolol, nebivolol, and metoprolol, are safe in patients with chronic obstructive airway disease. The one which making a lot of bronchospasm is carvedilol, which should be avoided in people with COPD. In those patients, also we should slowly titrate the dose of beta blocker at 1 to 2 weekly interval up to usual maintenance dose. This is important point. I came across it, mentioned that monitor supine and erect blood pressure, heart rate, and spirometry during dose titration. So in those people with COPD, that we are putting them on beta blocker for any reason, we should monitor spirometry when we are going to up-titrate the dose. I have 2 slides remaining here. Just to have a take-home message, I make the home message like that. The indication for beta blocker, any patient with beta blocker are widely should be used in patient with heart failure with reduced ejection fraction, because they will reduce the mortality and reduce hospitalization. So please, according to the guideline, this is guideline-mediated, guideline-directed medical therapy. Any patient with heart failure with reduced ejection fraction, beta blocker should be given unless they are contraindicated, because they will decrease mortality and hospitalization. In second part of our presentation, we have talked about heart failure with mid-range or preserved ejection fraction. Until now, we have no adequate data supporting the use of this medication, but when they are indicated, they can be used for other reasons like hypertension, atrial fibrillation. When the patient have got atrial fibrillation, is indicated. In post-acute coronary syndrome, definitely beta blocker should be given. They have got 2 effects. The first one, immediate effect, they will reduce mortality and infarction, and in long-term effect, they will also reduce the mortality. In those patients with chronic coronary syndrome, give beta blocker only to relieve angina. It doesn't have any effect on the mortality. My last slide, only bisoprolol, metoprolol, and carvedilol proven by randomized controlled trial to be effective in patients with heart failure with reduced ejection fraction. So only these 3 beta blockers. Gradually up-titrate the dose till you reach the target. Beta blocker might impair erectile function. Nebivolol may be the solution. Beta-1 selective antagonists such as bisoprolol, nebivolol, and metoprolol are preferred in patients with COPD when the A-beta blocker are indicated. And thank you very much for your kind time. Thank you.
Thank you very much, Aram, for this high quality, elegant presentation. You just raise up many points that affect our clinical practice. راح أقول الكلام شوي بالعربي حتى تكون المسجز توصل أكثر. هواية نشوف من المرضى اللي يجونا عندهم heart failure قد يكون هم مو on beta blocker. القسم الثاني قد يكونون هم on beta blocker لكن الدوز of beta blocker is not up to the level required in the guideline, ولذلك المريض ما ماخذ الماكسيمم benefit of beta blocker. ثلاثة مو كل المرضى أهل الهارت فيلير هم one group بحيث كلهم they are fit in this category. مثل ما قال دكتور آرام اللي عندهم low ejection fraction ذولا 100% indication. Those with low preserved or mid-range ejection fraction الفائدة تكون قليلة unless there is other indication for beta blocker such as dysrhythmia, hypertension or ischemia. الفورث بوينت دائما الفير from impotence and side effect هذا راح نناقشها بعدين في نهاية السيشن، لكن أنا أريد تفكرون بهذه السيناريوهات اللي أتكلم عليها. الشيء الآخر بالنسبة للأكيوت كورونري سيندروم كان فرانك الانديكيشن، أما بالكرونيك ستيبل أنجينا إذا المريض ما عنده أنجينا هو حتى بالاكيوت كورونري سيندروم الجايد لاين تحكي up to 3 years، بس بعد ال 3 years ما راح تلاقون جواب قاطع هل نستمر بعد 3 سنوات او لا. اذا المريض ما عنده هارت فيلير وصار عنده اكيوت كورونري سيندروم ومشى 3 سنوات وراها الجايد لاين ما تحكي. قسم منهم يقول لك انت as long as there is no side effect you can go with it especially if the patient is hypertensive او اكو other indication للبيتا بلوكر. لكن اذا المريض ما عنده او عنده انجينا، اذا ما عنده انجينا وما عنده LV dysfunction تنطي بيتا بلوكر وتستمر عليها اور نوت. تخيلوا ايضا هذا السيناريو، وراح اجل الموضوع بس اريدكم تفكرون بالسيناريوهات اللي تكلمنا عليها الى نهايه السيشن ورا ما يكمل الدكتور علاء. دكتور آرام بلا زحمه عليك بس توقف الشير سكرين مالتك حتى دكتور علاء يبدي.
اوكي سي.
Okay, now we are coming to our second distinguished speaker, Dr. Ala Al-Sheikh, will talk about beta blocker in hypertension and in patients with a chronic kidney disease. Dr. Ala, the floor is yours.
شكرا جزيلا أستاذ. شكرا جزيلا. I hope أنه الصورة واضحة. إذا
بعدها ما طلعت بس ننتظر. Okay. Yes, now is clear.
Okay, now?
Okay, now it's clear. Yes.
بسم الله الرحمن الرحيم. مساء الخير جميعا عليكم. شكرا جزيلا أستاذنا دكتور هلال الصفار for the presentation. Thank you for Merck team for endorsing and sponsoring this educational event. I hope it will be delivering the message as presented by Professor Hilal Al-Saffar. My task was to talk about beta blockade in hypertension and the chronic kidney disease. So we will go through some background issues, how the evidence were changed since the initiation and continuation of beta blocker and treatment of hypertension. And definitely we will go for some points regarding the use of beta blockade in chronic kidney disease. I have nothing to disclose. So to go from the background, beta blocker are drugs that block the adrenergic receptors. And these adrenergic receptors that have been discovered for the first time in mid-20th century by Professor Raymond Alquist, who described them as G-protein coupled receptors, that they are targets for many endogenous catecholamine like epinephrine, norepinephrine, and these the drugs have been called as beta blocker. The first beta blocker was called dichloroisoprotrinol, have been admitted in 1958, and as Dr. Aram said, Sir James Black described propranolol, who is the most famous one of beta blocker, in 1963, and year after year different types of beta blocker have been described and admitted to the market. To go back to the pharmacology basics, beta blocker have been classified according to their selectivity to the adrenergic receptors. Some of them are non-selective, some of them are selective, and some of them they have both beta and alpha blocking activities. And again, there is a very important pharmaceutical and pharmaceutical point of view that need to be considered when prescribing beta blockers, which is whether this drug have what is called intrinsic sympathomimetic activities. And this has a very important implication regarding hypertension management and the management of heart failure, as we will see. Here you can see the different generation of beta blockers, and those which are shaded with green, these are the most commonly widely used drugs specifically in our Iraqi practice. Definitely still we are using propranolol, bisoprolol, metoprolol, carvi, labetalol, and nebivolol, the recent one. And all these drugs act on myriad organ in the body: heart, kidneys, lung, liver, the blood vessels, the bladder, the ureter, and even on adipose tissue and the bladder. And at each site, they may have the agonistic or antagonistic action that will lead to the therapeutic implication or the drawbacks of the medication. So to start with, we should reflect our current practice. This is a very interesting Iraqi data from the city of Baghdad that have been produced in a collaborative work with the Iraqi Society of Hypertension. Still, Iraqis are not achieving adequate control of their blood pressure. It is only 38.7%. Male gender and those who are less than 60 years old and diabetic, they are the least controlled. But what about the type of therapy? In Iraq, still the majority they are using monotherapy. And strikingly, in spite of admission of many antihypertensive medication, about 30% of hypertensive Iraqis, they are still using beta blocker, either as a single agent or as a combination therapy. So this area should be focused, and we should direct our therapeutic implication to reflect the patient data. Since 1985, which is the first trial that used propranolol for the treatment of hypertension, which is the MRC trial, until 2003, there were a plethora of evidences that support the use of a beta blocker as first-line antihypertensive medication. These trials used propranolol, atenolol, metoprolol, and either as a single agent or as in a comparison with other antihypertensive medication like calcium channel blocker, ACE, or ARBs. And in comparison with that, this is the timeline of guidelines of hypertension management. The first JNC report was in 1979. And since that guideline in the 70s and until 2003, where JNC7 had been produced, beta blocker was regarded as a first liner in the treatment of hypertension. And in 2003, with the JNC7, when thiazide diuretic regarded as a first line and all other medication regarded as a secondary or add-on therapy. But strikingly, after the JNC8 recommendation in 2014 by the International Institute of Medicine, beta blocker have been relegated from being a first-line therapy for treatment of hypertension. So why this occur? Here you can see the recommendation from the JNC8, and in all steps in this algorithm, there is no beta blocker therapy, as you can see in different areas. And what is the rationale for them? They used the term that it should be used whenever there is a compelling indication, mostly cardiovascular compelling indication, diabetes, kidney disease, and we should never forget pregnancy, as labetalol, one of the beta blocker, is a first liner in the treatment of hypertension during the pregnancy. So what are the concerns that change the idea, that lead to a good evidence of stop endorsing beta blocker from being a first-line therapy. These are sample of the studies that have been conducted in different areas from 2002 to 2012. And these raised many concerns. But the main important concern for the relegation of beta blockers from being a first-line therapy is the increased rate of stroke and the possible metabolic drawbacks. That's to say, the possible increment role of new onset diabetes mellitus and the old report that beta blocker may alter the lipid management and lipid profile in those patients who have definitely need to address their lipid management during their acute coronary syndrome, heart failure, or chronic kidney disease and diabetes. So these are the main risks that led to removing beta blocker from being the first line for treatment of hypertension. So in 2014, with the JNC 8 recommendation, this was the end of the road for beta blocker to be as a first-line therapy. But this is not the final issue for beta blocker. There are certain evidences to use them whenever there is an indication that support the use of beta blocker, or with the new generation of beta blocker that is called the vasodilatory beta blocker, which may be safe. And here you can see the different studies from different respected journals. This have been supported in 2017 by an excellent systematic review from the Cochrane Review, who suggested that beta blocker effects are inferior to those of other antihypertensive drugs when compared in head-to-head studies as potency for antihypertensive medication. But these, regardless of their potency, they are beneficial when there is specific indication. In a very recent paper from the Journal of Hypertension, they described that when compared with other antihypertensive agents, beta blockers appear to be substantially less protective against stroke and overall mortality, but still they are beneficial at certain indication. All these have been supported by the recently delivered global guideline of the International Society of Hypertension that have been published on May 2020. Here you can see that the treatment algorithm of this guideline, that there is no any role for beta blocker here. It is to start with ACE, ARBs, calcium channel blocker, thiazide-like diuretics, and beta blocker should be reserved for certain indications only. So thank you for Dr. Aram, who shared the ideas about the use of beta blocker of coronary artery disease and heart failure, so I will skip them. And the other important one is the use of beta blocker in patients with diabetes mellitus. Although there are data that there may be adverse metabolic and lipid consequences of a traditional beta blocker that raises some concern in the 80s, there seems to be an increased incidence of new onset diabetes with the use of atenolol and propranolol. Fortunately, the new drugs like carvedilol and nebivolol have shown a neutral or beneficial effect on metabolic parameters, and this have been approved by two important trials, the Gemini trial and the Yestono study in 2007. Dr. Aram thankfully mentioned some data about the use of beta blocker in patients with COPD. There is a big debates whether it is a myth or reality to use beta blocker in such condition. And here we should be able to distinguish what type of obstructive pulmonary disease we need to choose beta blocker in them. The pathology of asthma is not the same of the pathology of COPD. So, according to the expert review from pulmonology colleagues, in asthma, non-selective beta blockers should not be prescribed for the management of comorbidities in patients with asthma, while cardioselective beta blocker, still to be used in low doses, may be used when strongly indicated and there are no other therapeutic option. In COPD, the data are still limited. Observational studies only are the source of evidence, and they are unsupportive for non-selective beta blocker. There is an ongoing big randomized controlled trial that is called the BLOCK COPD, the result of which will be necessary to eliminate the uncertainty from residual confounding bias. But if we go back to 2014 JNC8 recommendation, they described that nebivolol, carvedilol, and bisoprolol may be used at lower doses in patients with COPD. What about the heart and the kidney? You all know that in patients with chronic kidney disease or end-stage renal disease, we as a nephrologist, we are preferring to use ACE, ARBs, or calcium channel blocker. And here you can see beta blocker are still of value to be an add-on therapy. And atenolol have been studied well for a very long time, and it is a very long-acting and effective for hypertension. But as we should tailor treatment for each patient in the era of personalized medicine, we should consider that not all beta blockers are dialysable. Atenolol is highly dialysable, so it will be cleared easily through dialysis, and it will not correct blood pressure surge during dialysis. The least dialysable is carvedilol, and the second least dialysable is bisoprolol, and these can be used in a good way through the dialysis process to manage hypertension surge during the hours of dialysis. You all know that CKD are almost always associated with cardiovascular complication. The most important common cause of morbidity and mortality in patients with CKD is cardiovascular disease. And these are very recent meta-analyses that suggest that the use of beta blocker in patients with cardiovascular disease, mainly heart failure and ischemic heart disease, in patients with CKD or dialysis, they will reduce mortality. And the evidence have been reproduced over about 10 years from 2011 to 2019. What are the recommendations by the guidelines? The AHA-ACC guidelines support the use of beta blocker in patients with comorbid CKD and heart failure. The KDIGO guidelines for the nephrology recommends beta blocker therapy, but it suggests dose reduction by 50% when to start for those with stage 4 and stage 5. This is to avoid the unnecessary complication of bradyarrhythmia after the initiation of beta blocker. Still, we are in need, from the nephrology perspective, I say, we need better design and larger cohorts. In conclusion, although beta blocker no longer be undisputed leader in the management of hypertension, they still hold a special place in the treatment of cardiovascular diseases, including hypertension with compelling indication, because an acceptable cost effectiveness and reasonable adverse effect profile. The reality of modern hypertension treatment is that most patients will require multiple drugs. And here is another idea to add beta blocker as an add-on therapy in patients with comorbidities. Combination therapy will be essential. Third generation vasodilating beta blockers have many advantages over their predecessors and should be preferred whenever possible. In all areas of medicine, and specifically in patients with CKD and hemodialysis, a careful selection and the prescription are needed to tailor the best management for the best patient. Thank you for all your attention and for all your effort in managing your work during such tough times. Thank you.
شكرا جزيلا دكتور علاء for this high quality, again, elegant presentation. Please stop your screen share
Yes.
and so that we can start the discussion. اكو تعليق بالحقيقة من دكتور قاسم مدلل إلى دكتور آرام. يمكن تقرأ آرام أو لا. يقول thank you for nice presentation دكتور آرام. In the ESC guideline nebivolol is also approved for heart failure beside bisoprolol, metoprolol, saxonate, and carvedilol. This information, shukran Dr. Qasim for this addition. May I ask to share video, Dr. Aram, Dr. Ala,
Yes.
please share your video and then we can start the discussion. Till waiting your questions, أي واحد يحب يسأل ممكن يطبع سؤال على chat وممكن نجاوب عليه أو we ask the presenter to answer the question. دكتور علاء أنا عندي لك كم سؤال just for يعني verification to the audience ونفس الشيء بالنسبة لدكتور آرام. دكتور علاء هسه إذا إجاك مريض عنده hypertension وعنده خلينا نقول stage 2 or 3 renal impairment يعني الجي اف ار مالته ما بين 30 ما بين 60 correct me if I am wrong للستيج مالت الرينال امبيرمنت وتريد تختار عندك indication للبيتا بلوكر خلينا نقول عنده انجينا تريد تستخدم بيتا بلوكر which one you will go first which is your preference.
شكرا جزيلا استاذ. This is a very practical issue regarding the staging. طبعا احنا 30 and below it is the stage 4 so we should be up more than 30 و stage 3 تقسم إلى stage 3 A و B أقل من 45 إلى 60 وهكذا. البيتا blocker when there is طبعا for the control of blood pressure beta blocker in such patient is not enough. We will need to choose a an antihypertensive medication, let's say ACE or ARBs, but when we need to use a beta blocker for such patient, if there is an evidence that we need to control the rates like that acute coronary syndrome or angina, the new third generation drugs and the bisoprolol from the second generation are the preferred option. For those patients with heart failure, associated heart failure, carvedilol is most widely used, metoprolol and bisoprolol, and recently nebivolol, all can be used. The most widely studied is carvedilol for treatment of heart failure. And for control of rate, if we need rate, metoprolol is the most widely studied in patients with hemodialysis and CKD.
Okay. السلايد طلعته اللي كان be the most dialysable as atenolol. انت هنا
Yes.
تقصد انه is that a message for those patients with end stage renal disease يعني اذا كان الجي اف ار below 10 وهم on dialysis وهم اكو indication للبيتا blocker you prefer to use atenolol?
No, sir. As much the drug is dialysable, so it will be cleared through dialyzer. يعني ببساطة إذا مثل ما تقول جنابك نحكي بالعربي يعني اللي راح ننطيه منه راح يطلع ويا الدياليسيس. So this it will not exert its effect. We need a drug that cannot be dialyzed, that can stay in the body and not excreted through the dialysis machine in order to produce its effect. لأنه intradialysis there may be surge in blood pressure and sometimes one of the main points that atrial fibrillation or SVT occur in such patient is during dialysis. You need to control the drug. So here carvedilol and to lesser extent bisoprolol are preferred agents.
اوكي هو هذا المسج اللي اوصلها للاودينس يعني انت المريض اذا عندك انديكيشن للبيتا بلوكر ما راح نروح بالانديكيشن اذا عندنا انديكيشن وعندنا رينال امبيرمنت سواء انه كان end stage on dialysis او كان stage 3 to 4 without dialysis the indication is that for carvedilol or bisoprolol or metoprolol saxonate for whatever indication you want to do. Is that
تمام استاذ. السبيسيفيكيشن النقطة المهمة يعني إذا أريد نروح نفوت بالتفاصيل يعني to touch it if a patient with heart failure with reduced ejection fraction هنا carvedilol and bisoprolol are preferred. while those if with coronary syndrome that need to control the rate, metoprolol is the preferred one. This is still observational study from the nephrology horizon. فممكن واحد يروح more specific to tailor the treatment.
Okay. سؤال إلى دكتور آرام.
Yes, sir.
What are آرام your objective in using beta blocker? تعرف دائما الكلام whether to reach the maximum dose that is present in the guideline or to get a target heart rate. تعرفون حضراتكم الهارت ريت ده تصير الآن راح يجي وقت تكون تارجت بالمانجمنت مثل البلد بريشر ليفل. يعني الآن احنا الهايبرتنسيف نقول لازم احنا نكون less than الجايد لاين نقول less than 130 over 80. هذا threshold لازم نسويه بالمرضى اللي عندهم هايبرتنشن مثلا whatever the comorbidity الأخروية. الهارت ريت الآن ده يصعد سوقها كلش هواية وده يصير ريسيرش عليها كلش هواية ويقول لك الآن قد يكون اكو تارجت هارت ريت لازم توصلها بالمانجمنت to prevent cardiovascular problem. إذا آرام استخدمنا بيتا بلوكر in a patient اللي هم يجوك اللي عندهم ischemic heart disease شنو هو your threshold? What are your target تقول أني وصلت adequately I adequately beta block my patient. هل هو الريت أو هو الدوز اللي هو usual بالجايد لاين؟
Thank you very much, sir, for this nice and clinical question. Actually, it depends on the situation. I think that there is no a clear rule to say that they have got a number. I should reach a number for to say that 60 or 50 or something like that. There are not a precise number that you should reach it with a beta blocker. But definitely, one of the aim of giving beta blocker is to decrease the rate. It's unwise when I'm putting a beta patient on beta blocker and he came back to me and the pulse rate is hardly is 90 or 85. So it's an logic. So, yeah, the lower is the better. But definitely, I came across a lot of literature. Nobody say that. Please go to that number. There is no precise number. But generally speaking, lower is better. Lower. But what's mentioned in the guideline, what we are talking about, the guideline mediated directed medical therapy is that we should go to the maximum dose of the beta blocker. Maximum dose, unless there are not good benefit. Why this? Because if we go back to the pathophysiology, we want to block the action of catecholamine and of adrenal of catecholamine. If still there is activation of catecholamine, if we again a small dose or a smaller dose that which is indicated, still activation, there will be chronic activation of the adrenergic system, of the release of the catecholamine, and so they will lead to a lot of adverse problem. So the main aim of giving beta blocker is to give the maximum dose. But as you mentioned that heart rate is very important. Lower is better, but there is no precise number to say that please reach to. It's a different story, and unlike hypertension. In hypertension, they told us please keep the blood pressure in patient with diabetes mellitus below 120 over 80, and patient chronic renal failure to this level. But in heart failure, there is a not precise number, but please reach to the maximum target dose. The lower the pulse rate is better.
Thank you, Aram.
Yes.
بالحقيقة this sorry.
العفو استاذ لا براحتك.
يعني هذا مهم جدا. احنا هوايه نشوف مرضانا هم اسكيميك وقاعد يمك انت بعد ما فحصه الريت مالته 80 و90 و95 وهو محطوط على 2.5 بايسوبرولول او 6.25 كاربيدولول. ويعني هو انت استخدمت البيتا بلوكر بس لازم تعرف بالضبط what is the principle behind that at what is needed behind that. اكو بوينت مهمه بالحقيقه من تصعد انت بالدوز مالت البيتا بلوكر to the usual in the guideline ممكن تواجهك مشاكل والليترشر تحكي على مجموعة من المشاكل من ضمنها خصوصا بالهارت failure the patients might deteriorate. This is the first issue. Second, he may go into bradycardia or hypotension and excessive fatigue. فحقيقة واحدة من الليترشرز قريتها is very nice. إذا عندك مريض heart failure وأنت خال على diuretics و ACE inhibitor or ARBs وخال على بيتا بلوكر، وتصعد البيتا بلوكر دوز. طبعا بالمناسبه قال ارام السمولست دوزز، وتصعد كل اسبوعين يو انكريز ذا دوز اوف ذات بيتا بلوكر، مو اقل من اسبوعين الانكريمنت بالدوز مالتك، not less than 2 weeks الى ان تصعد بالدوز الاخرى. بس انت دا تريد توصل للدوز اللي موجوده بالجايد لاين، دا تواجهك انه المريض يصير هايبوتنشن او دا يصير براديكارديا او دا يصير اديما فلويد ريتنشن يصير عنده. The recommendation is that إذا المريض ما عنده volume overload عالي، قلل الدوز مالت الدايوريتكس واصعد بالدوز مالت البيتا بلوكر، لأنه تعرفون الدايوريتكس it is a symptomatic treatment. It doesn't affect the mortality. It's only for symptoms. بينما البيتا بلوكر it will prevent the further deterioration of heart failure, rehospitalization, as well as mortality. فاللسن هنا إذا واجهكم هيك موضوع تقلل الدوز مالت الدايوريتك especially if the patient is dry and increase the dose of the beta blocker إلى أن توصل إلى required dose مالتك. النقطة الثانية دكتور آرام تكلمنا على الامبوتنس. اكو ستدي حلوة I came across it. شافوا اخذوا جروب من المرضى، قسم يعرفون انه البيتا بلوكر ممكن يسوي امبوتنس، وقسم ما يعرفون، وطوهم اثنيناتهم بيتا بلوكر. At the end of the study 30% من المرضى اللي هم يعرفون البيتا بلوكر يعني عندهم داتا عنها انه تسوي امبوتنس شكوا من امبوتنس، مقابل 3% فقط من المرضى اللي هم ما يعرفون البيتا بلوكر تسوي امبوتنس صار عندهم امبوتنس. اذا السايكولوجيكال فاكتور از فيري امبورتنت هنا، ولازم نخلي في بالنا موضوع ثاني ايضا انه the disease already the disease اللي هو المريض عنده such as the hypertension او الديابيتس او الاثيروسكليروسيس by itself as well as the diuretics والسبيرونولاكتون الالدوستيرون antagonist as well as may cause impotence. We have to keep this in mind and we have to balance between the benefit and the risk to the patient. اكو سؤال الى دكتور علاء.
نعم استاذ.
ايضا من دكتور قاسم. دكتور قاسم very active. Thank you for nice presentation, Dr. Ala. What are the features of nebivolol that make it a drug of choice in diabetic beside carvedilol? Carvedilol has vasodilator, doesn't cause dyslipidemia, antioxidant, affect insulin sensitivity and improve insulin resistance. So, سؤال دكتور قاسم يقول what are the features of nebivolol that make it a drug of choice in diabetic beside carvedilol?
شكرا جزيلا دكتور قاسم. بالحقيقة أعتقد يعني دكتور قاسم جاوب السؤال اللي سأله نفسه. الفكرة كالآتي. The recent guidelines that have been published 1 month ago for the management of diabetic chronic kidney disease, for example, there is no specific beta blocker to be prescribed in patients with diabetes. There is no specific selection. All the important idea is that you should use, if you need to use a beta blocker in a patient with diabetes, you should consider the following points اللي هو ذكرها الدكتور قاسم. It should be of a vasodilatory effect. This is very important. It should not interfere with the metabolic profile for the diabetes and lipid, and we all know that the newer generation اللي هي carvedilol, nebivolol and bisoprolol have no relation. It should have antioxidant, and there is no data that the beta blocker is affecting insulin sensitivity. الحقيقة diabetic patients, specifically whether they are in a chronic kidney disease or without a chronic kidney disease, usually need more than one antihypertensive medication. Sometimes need 3 or even more, including diuretics. And the addition of long-acting vasodilatory beta blockade may be very beneficial as an add-on therapy for those patients who are using ACE, ARBs, dihydropyridine calcium channel blocker, and with the addition of vasodilatory beta blocker. النقطة الفيرست جنريشن من النبيفولول كان اكو بيها النبيفولول hydrochloride that cannot be used at GFR below 50. Now the newest generation اللي متوفر بالسوق عندنا يعني بالإراكي ماركت حتى نكون إراكي perspective ناخذها, they can be used at lowest GFR, specifically if those patients develop cardiovascular disease.
شكرا دكتور علاء. وشنو ذكر كان التوك سابقا على البيتا بلوكر will inhibiting the process of gluconeogenesis والrecovery
نعم
مالت
سر.
diabetes in a patient with hypoglycemia إضافة
Sure.
effect, bad effect on the LDL. What's about that?
So the first report, the first report about the deleterious effect of using beta blocker, mainly propranolol, in altering lipid metabolism طلع بسنة ال 65.
نعم.
Through that, with the increasing understanding of the sympathetic pathophysiology اللي أفاض بها دكتور آرام, شافوا إنه non-selective beta blocker will mask the symptoms of hypoglycemia لأنه symptoms of hypoglycemia are mainly related to sympathetic activation. So if you are using a non-selective beta blocker that it block all the receptors, there will be pre-monitoring symptoms of hypoglycemia. There will no be sweating. There will be no significant tachycardia. حتى لذلك alteration and the awareness regarding the occurrence of hypoglycemic event ما راح ينعرف. And as you know, and all we know, that with the chronic diabetes, the awareness, the brain will aware much less to hypoglycemia. So those patients specifically with type 1 are more liable to develop hypoglycemic events. فإذا ننطيهم احنا non-selective beta blocker راح تصير هاي المشكلة. النقطة الثانية, بعض الدراسات شافوا انه use of non-selective beta blocker, certain animal study أمانة, شافوا انه they may have some certain toxicity on islet cell in the pancreas, so they may be associated with the new onset diabetes. لذلك اتجهوا على المور selective form اللي ما بيها مثل ما قال دكتور قاسم.
شكرا جزيلا دكتور علاء. أنا قبل ما أختم وأنطي في final messages أشوف أي إضافة إلى دكتور آرام, أي شيء, anything you want to add?
Thank you very much, sir. Actually, what I want to say in the last is that beta blocker is the cornerstone for the treatment of heart failure with reduced ejection fraction, and in those patients with acute renal syndrome. But please, let's keep in mind to do not stick to a fixed dose of beta blockers. Let's go to up-titrate the dose, but it should be very carefully. Even in those patients, we missed to stick about those patients with cardiogenic shock. It's mentioned that on those patients with cardiogenic shock, if basically the patient of beta blocker, we are not going to withdraw, or we are not going to stop beta blocker suddenly. We are going to decrease the dose until the patient will get hemodynamically more stable. So dosing of beta blocker is very important. What the mission is that when we prescribe the beta blocker for it is indication, let's go to the maximum target dose as mentioned by the guideline directed medical therapy. And thank you very much, sir.
شكرا دكتور آرام. دكتور علاء, أي إضافة عندك؟
شكرا جزيلا أستاذ. بالحقيقة I would like to mention some practical points that have been learned مع حضرتك وأساتذتنا regarding the effect of dose and how this will effect of dose on the pulse rate and how this have a clinical implication. سابقا there was a recognized notion in the textbook of medicines that if you need to know how much your patient is adequately beta blocked, his resting pulse rate should be in around 60. And his blood and his pulse rate should not exceed 100 with exercise. This is at some point was a standard notion for all physicians. Recently, as you said, that it is not only the rate, still this maybe has some validity, but nowadays not only the pulse rate as a number, it is pulse rate variability, and recently the blood pressure variability are associated more with serious complication. Beta blocker may inhibit the variability of pulse rate, but unfortunately on long-term basis, specifically with ambulatory blood pressure monitoring for patients with beta blocker, and you are the expert in Iraq in this issue, the variability of blood pressure for patients using beta blocker on ambulatory blood pressure monitoring is not that consistent, and that's why it is mostly associated with the risk of stroke. بالنهاية طبعا شكرا جزيلا لحضرتك وشكرا جزيلا لكل التيم ولكل الاتنديز. شكرا جزيلا.
شكرا. أنا قبل ما أختم أريد بوينت تبقى بالبال. إذا السكرين واضحة قدامكم.
نعم أستاذ.
نعم.
اوكي، المسج الاولى بالهايبرتنشن اللي طرق لها دكتور علاء. hypertension without heart failure or ischemic heart disease beta blocker are not first line. Our second line can be added. اما المرضى اللي عندهم hypertension with heart failure او ischemic heart disease لا تصعد البيتا بلوكر as a first line. المسج الثانيه بالحقيقه بالبيشنتس اللي عندهم heart failure مثل ما قال دكتور آرام، كل المرضى اللي عندهم low ejection fraction definitely indicated. اما المرضى اللي عندهم mid range او preserved ejection fraction تستخدم البيتا بلوكر اذا اكو other indication. الانديكيشن اللي هو قد يكون hypertension او arrhythmia او انجينا، طبعا ممكن تستخدم البيتا بلوكر بيهم. الانديكيشن او الجروب الثالث اللي هم ischemic heart disease، كل الاكيوت كورونري سيندروم اللي يفوتون up to 3 years very important ولها effect على السرفايفل. اما الكرونيك ستيبل انجينا اللي ما عندهم past history of myocardial infarction or heart failure فتستخدمها اذا المريض السيمتوماتيك انجينال. واذا هاي عكسناها على البراكتس مالتنا، تشوف مريضنا مثلا عنده كرونيك ستيبل انجينا وهو ما عنده سيمتومز وصار له 15 سنه ياخذ تينورمين مثلا، او ونفس الشيء وياها ايزورديل ايضا مستمر عليها وهو ما عنده سيمتومز. فبليز اخوان، الغايه من هالتقديم اليوم احنا شلون نحول الجايد لاين الى البراكتس مالتها، وشلون نطبق البوينت اللي العالم كلها وصلها بالريسيرش وبميتا اناليسيس مال الستدي. الشيء الاخر الدراجز الثلاثه المهمه اضاف لها رابع دكتور قاسم مدلل، اللي هي بايسوبرولول، ميتوبرولول، ساكسونيت. شوفوا ميتوبرولول، ساكسونيت والكارفيدولول اللي تستخدم باللو ايجكشن فراكشن هارت فيلير. البوينت المهمه الاخرى هي start as early as possible، حتى لو كان المريض عنده past history of heart failure او عنده mild stage يعني نيها كلاس 2، شافوا initiation of beta blocker تقلل ال deterioration، improve survival، تقلل readmission to hospital. still ممكن نستخدمها بالchronic obstructive airway disease. دكتور علاء فصلها elegantly، فرق جماعة الأسمى عن جماعة chronic obstructive airway disease، بس still can be used بsmall doses وبspecific beta blockers. ال very small doses نبدي بيها بالدراجز، مثلا بايسوبرولول 1.25، ميتوبرولول ساكسونيت 25 ملغ، وكارفيدولول 3.125 ملغ ان انكريزنج. لازم ما تزيد باقل من فتره اسبوعين بين دوز واخر. توصل للماكسيموم دوز ايضا دكتور آرام ثبت الحقيقه، البايسوبرولول 10، ميتوبرولول ساكسونيت 200، التارتريت 150، والكارفيدولول 100 ملغ. هي هاي الدوز اللي شافوها امبروف سرفايفل بالجايد لاين، الا اذا مريضك صار عنده سايد افكت، هايبوتنشن، براديكارديا، وورسنينج هارت فيلير الى اخره. الابربت withdrawal واحد كل شيء يدير باله، it's contraindicated for any beta blocker. You have to gradually down regulate your treatment until you stop it over a period of 7 to 1 to 2 weeks time، حتى نمنع ريباوند اللي ممكن تصير عند المريض because of the stopping rebound. شكرا جزيلا. أنا بالنهاية أتقدم بالشكر الجزيل لشركة ميرك اللي رعت هذا الميتينج، إلى دكتور آرام ودكتور علاء for their high quality, for their elegant presentations, for their focus messages وصلوها. أتمنى كانت مفيدة للجميع، وإن شاء الله نلتقي على خير بسيشنات أخرى تكون مفيدة في حياتكم العملية.
شكرا جزيلا.
Anyone who want to add من ميرك؟
Thank you very much, Dr. Hilal, Dr. Aram, Dr. Ala, for this nice interactive sessions. And we are in Merck proud to support our doctors in such medical events. وإن شاء الله بالمستقبل القريب رح تكون إيفنتات أكثر وياكم. Thank you very much, Dr. Hilal.
شكرا جزيلا للجميع، وليلة سعيدة وتصبحون على خير.
شكرا جزيلا.
تصبحون على خير إن شاء الله.
مع السلامة. مع السلامة.